Welcome to this program by The Ohio State University on coordination of care for the early identification of lung cancer that was presented by a panel of experts from the university. Each panelist spoke about a different topic in the early identification of lung cancer. In this video, Dr. Chiemezie Amadi discusses the radiographic assessment of detected nodules.
Good evening. My name is Chiemezie Amadi. I'm a cardiothoracic radiologist. In my 7th year, I serve as a liaison officer for the radiology department to our oncology program. It's a great pleasure to be part of this panel. I'm going to repeat some of the things that we've talked about here previously to go through Lung-RADS. As we have heard, lung cancer is the number one cause of death. And like Dr. Carbon said, a lot of times you could have a mass in your lung and you'll be asymptomatic. And these patients can come in at a late stage, at which point they've already had mediastinal invasion of critical organs, at which point it's difficult to treat. So the whole goal for us is to catch these patients at an early stage. And that's how we could decrease the mortality associated with lung cancer. The NLST was a trial that was published in 2011, and it was using low-dose CT to evaluate patients at high risk. So basically smokers who had smoked for a certain number of years. And they found that there was a 20% lung cancer-specific mortality improvement in these patients. Based on the results from that NLST trial, ACR, American College of Radiology, came to develop what we call Lung-RADS. Lung-RADS basically is our reporting system that we use for patients who are part of a screening program. And the word I use is a screening program because it's not just one study. We have to see these patients on a yearly basis and get images of these patients. So it's a program. Lung-RADS was developed in 2014. There are basically 6 elements to the Lung-RADS. The pictogram I have there is basically Lung-RADS 1.1, which was an addendum that was completed in 2019 to the original Lung-RADS from 2014. There are 6 elements to the Lung-RADS assessment. We describe the category. We talk about a score. Each score has specific findings based on the type of nodule you're dealing with. Are you dealing with a solid nodule? Are you dealing with a part solid nodule? Or are you dealing with a ground glass nodule? Does the nodule have components of calcium, which could be benign, or fat, which is a benign finding? What's the management in these patients based on the nodule score? And what's the risk of malignancy? And what is the estimated prevalence of those patients among the group? This pictogram is quite complex, so I'm going to present to you a simplified model addressing some of those elements. So it addresses 4 of the elements, not all the elements. When we score patients as part of a screening program, we don't use this for patients outside of the screening population. When we use low-dose CTs and the patient is part of a screening program and we score these patients, we give certain categories of score from 0 to 4x. What does that mean? The category description. So if we're giving someone a Lung-RADS 0, it means that the study is incomplete. We need additional images, additional studies to fully give our analysis on that patient. If you have a Lung-RADS 1, it's a negative study. Lung-RADS 2 is a benign study. Lung-RADS 3 is probably benign. When we get to 4A, then we're dealing with suspicious finding. And a 4X is a patient that has a lung nodule with aggressive features. For example, the nodule is spiculated, or the nodule is associated with mediastinal or hilar lymphadenopathy, or the nodule or mass is breaking through the chest wall and infiltrating on the osseous structures. So those are all very suspicious findings, and those are patients with high-grade cancers. For the most part, there's a high risk, over 15% of having malignancy in those patients. As you can see on the table, we have management guidelines for each series. I'm going to go through a few cases just to tell you what we're talking about. So this first case was a 61-year-old female with COPD. She had 40 pack years of smoking. She's a current smoker. She's quite asymptomatic. She came in due to referral from a primary care physician for a low-dose CT. And on the CT, she did have a moderate emphysema, central lobular emphysema predominant in the upper lobes. She also had multiple nodules in the lung. If you look at the third image on the top, and the first image on the bottom. Those are two different nodules. The image on the top in the right upper lobe was about 3 millimeters. The image at the bottom was 8 by 5. So you get a bidimensional measurement and you take the average. So we'll call it a 7 millimeter nodule. So a 7 millimeter nodule falls into Lung-RADS 3. It's probably benign, the 7 millimeter nodule. What we did for this patient was to get a 6 months follow-up. The last image at the bottom, I guess that would be the right-hand side, is just a coronal view showing the nodule from a different view. We put this patient in category 3, probably benign nodule. The management for this patient would be to get a 6-month study, and the risk of malignancy is quite low, 1 to 2%. At 6 months, the nodule was still persistent, still 7 millimeters. We downgraded the patient at that point to a Lung-RADS 2, and then we got a repeat study in 12 months, and at that time, the nodule disappeared. The next case is a 66-year-old female who routinely was sent by her primary care physician. She has a 35 pack years of smoking. She's asymptomatic. On review of the images, she had endobronchial nodule. A lot of times, patients with COPD can get secretions in the airways. They have mucoid secretion. They look different. The mucus is usually dependent in the posterior walls, and sometimes it has a bubbly character where you see some foci of air within the mucus. But this is quite suspicious because it's actually adherent to the anterior wall and also is very rounded. We want to make sure that this isn't a cancer or maybe a carcinoid tumor that has developed in this patient. Endobronchial lesions are 4A lesions. And for 4A lesions, how you follow them up is you could either get a repeat CT examination in 3 months, but if they are large enough, if they are 8 millimeters, you could go ahead and perform a PET CT examination. In this lady, the nodule was actually quite small. We decided to get a follow-up CT examination in 3 months. So this is a 4A category. Management is going to be 3 months low-dose CT, and risk of malignancy in this patient is between 5 to 15%. We repeated the study in 3 months, and the endobronchial nodule resolved. At 12 months, you could see that it's also gone. We downgraded this patient to a Lung-RADS 2. Finally, we have a patient, a 65-year-old male with COPD. He has a 95-pack year smoking history. Patient is a current smoker and is asymptomatic. We got the low-dose CT scan in this patient, and the low-dose CT scan revealed no nodules. However, the patient did have a finding. The patient had what we call interstitial lung abnormality. Basically, they had evidence of fibrosis in the peripheral lung, characterized by reticulopathies and granulopathies in this patient. This was a patient who had no lung nodules, had no evidence of lung cancer, so that would be category 1, a negative study, but then had interstitial lung disease, so that is a modifier S, which means that the patient has a significant finding. We do have a lot of incidental findings when we screen patients. Sometimes the incidental findings are enough to give the patient a category S. What we worry about in category S are things like if you have significant coronary artery disease, a patient might have an aneurysm, a patient might have a large gallstone, an obstruction. There's so many findings that could give you that category S. That's what we did in this patient. Negative study, Lung-RADS 1S. Just want to talk briefly about radiation dose. The NLST was done with usually 4 detector scanners, quite old technology. Today we have scanners that are 128 or 256 detectors. They have way more detectors. They're much faster. They could get thinner images. They could get greater images with lower radiation dose. What we're doing today is ultra low dose CT. Actually, the numbers we're getting today is in the second column. But this is just a comparison of the radiation exposure in patients getting low dose CT as opposed to patients getting other radiographic images, including a PET CT examination or mammography. That's it for me. Thank you very much. It was a pleasure.
Look for more videos on the early identification of lung cancer from experts at The Ohio State University.